basically, movies series how they started. It's called Good Doctor. It started after the house people who were there.
Aber auch schnell, kann man eine Stunde machen. Vielleicht auch morgens um 6 schon. Schon mal in die Tiefe Ey, jetzt meint man, der kriegt man hier schnell Telemedizin. Ja, man muss halt auch alles nehmen. Ich meine, der wird einen weiten Weg damit machen. Das erinnert mich stark an München. So kann ich das jetzt nicht sehen. Die sind ja auch.
By aaaaabbbccccc and Laureate Educational and Welfare Foundation, and the event is supported by Dr. Devi Prasad Shetty, Chairman of Narayana Health. With this, we begin the first speaker, Mr. Aga Sultan, Chairman of Laureate Educational and Welfare Foundation. I request him to please come over and introduce the gathering. A huge round of applause for the first speaker of the evening.
Good evening, ladies and gentlemen. Extremely sorry for the delay. There is a change in the schedule of operations here because Dr. Devi Shetty had to go on an emergency operation. So when the delegates came here, after seeing the ITU, he wanted to meet them, and believe me, he spoke for 1 hour with them, and then rushed to the operation theatre. We apologize to those who were waiting here. On behalf of Narayana Health, City, Laureate Education and Welfare Foundation, and I Care for Billion, I welcome the esteemed doctors from across the world, across the globe, spanning thousands of kilometers from almost 26 countries, and we have about 27 to 28 delegates. Especially I welcome Professor Dr. Rainer Sibyl from the Frankfurt School of Germany. Correct? Leading the delegation. And the names, I will not go through every name, but I will, for the information of the audience here, we have doctors from Saudi Arabia, Syria, Netherlands, Colombia, New Zealand, Qatar, Georgia, Tunisia, Germany, Hungary, US, UK, Dominican Republic, Peru, Egypt, Philippines, Romania, and of course our own country, India. Though you are only about 28, each one is an institution. You represent millions of your patients in your own country. And this we restricted only to you and a few students from Bangalore. We didn't make it a mass program so that you get the importance. And on behalf of Narayana Health, and on behalf of Dr. Shetty, on behalf of the entire team of NH and IK for Billion and Laureate Education Foundation, I extend a very, very hearty welcome to each one of you who have come today. And I'm sure you have visited other countries, other places. You will go back home with memories of Bangalore and especially memories of Narayana Health. I welcome you all and I request you all to give them an ovation, please. Dr. Divya Ramaswamy, who's been here from almost 5:30. I'm sorry, madam. You have been waiting too long, I know that. She is a senior faculty from Arvind Eye Care Systems. I welcome you, madam. I welcome Ms. Neelam Kachap, who is the editor of India Med Today, Dr. Girish, and the host of today is NH, Narayana Health City. We have with us a very young, dynamic captain, the Chief Operating Officer, whom I really appreciate his work. Whenever I call him, believe me, he is only for service and service. And he's not a doctor, but he's a damn good administrator. Mr. Joseph Pasanga. Welcome. I welcome Dr. Muhammad Raza. He is a professor of surgery from JSS College. And incidentally, he's the father of Ms. Ishan Ali, your team. I welcome the staff of NH and all the doctors from Bangalore who've come here, and my friends too. And of course, Dr. Ishan Ali is a part of the host. Anyway, I welcome you, and I welcome Dr. Zakriya Abbas from Laureate. I welcome each one of you, the photographer and the videographer here, especially the staff of NH. They've been very cooperative. I welcome them. Thank you very much.
Thank you, Mr. Aga Sultan, and he happens to be my father too. So it's, in events like these, so my father introduces me and I call him Dad, feel so proud. And being a part of such a great fraternity, I'm so excited because this is the beginning. And especially Dr. Zishan. Dr. Zishan Ali is my first cousin, he's my elder brother. And as a child, when I did my medical science, during my examination, it was him who used to guide me. And I thank him for all the guidance, and I'm very excited for this evening. With this, I want to call him up in the arena, and he's going to introduce the Eye Care for Billion, and he's the founder of this lovely initiative. I call him up on stage to please introduce his initiative. Huge round of applause.
Hi guys, good evening. Good evening to one and all over here. Firstly, I really apologize for the, little change of schedule. But nevertheless, welcome to India, all of you. Today to Stockholm to start on. You know, if you travel, and we have already started traveling the world, and I believe, my personal views, what every human needs, the basic necessity for living is health. And you are in a great country like India, which has a population about 1.3 billion people. The healthcare structure in India is definitely overburdened by increasing in population, 1.3 billion people. But I wouldn't take that as a negative. Rather take it as a positive notion, 1.3 billion people, 1.3 billion brains. All we have to do is educate them, streamline it and mold it for the better future and better outcome. As you see the parameters, what I believe the most important parameters in healthcare system comparing to the world is availability, accessibility, acceptability, affordable, quality, and equality. You know, let's compare to the people across the globe what the healthcare system of brief introduction. You know, last week I read an article about Frost & Sullivan, which clearly said that we're going to have $388 billion loss in diagnostic errors in US. Well, in US, there's definitely availability. But access to healthcare, again, they're facing the biggest challenge in it. When it comes to India, we've seen the two contrasts. You know, there's India within India. That's my part of saying, but the part of people who get access to healthcare, but some part of people lack access to healthcare. How we can help them and globalize, streamline to have 1.3 billion people to access is the biggest. Acceptability and equality, there's definitely varying in quality as well. So what I mean right now, you know, compare or a national issue, it's a global issue. So I believe that we all have to join together, each country, to learn from each other, educate from each other, and how we work together at the time of crisis, and how we share each other our innovations to put into come for a better healthcare, for the better future. With this initiative, ladies and gentlemen, I'd like to introduce the new initiative called I Care for Billion. What it means, we work on three main strategies. One, educating people. Educating about healthcare, about all these 6 parameters, and also we work, secondly, on networking to healthcare. When definitely we educate people through your network, the final comes is, any idea? Just atomic block. When you educate the people, you network the people, what is left behind? The most important, basic thing in healthcare. Anybody? Of course, affordability. So what we're going to do from I Care for Billion is we're going to streamline all the foundations to join in one hand to incorporate a small amount of pockets which are being not reachable in our country and of course across the globe in a future stage. So I'd like to show you a small video to introduce I Care for Billion.
I care
eye care for Billy. Thank you.
Thank you for sharing your insights, Dr. Ali. With this, we move on to the first speaker of the evening, Mr. Joseph Basanga, who's the COO of NH. He's going to speak about the very unique NH model. Please welcome him with a huge round of applause.
Hi, good evening. I think most of you have heard me this early this evening. And I won't repeat myself, but I'll just run through 20 slides. And most of them are self-explanatory. You can pause me if you have any questions. Most of them are statistics, and it's this is what Dr. Ali had said, 1.3 billion people, and then a lot of underserved population. So the journey so far for NH, from one hospital, that's a flagship hospital that you all met me at when you all came, to 31 hospitals today across the country. We have a pan-India footprint. 18 cities, 6,600 beds, over 2,600 doctors, and over 13,500 employees. The NH way, these are our 5 pillars, and the entire NH model is built around these 5 pillars: infrastructure, operational excellence, clinical excellence, innovation, social and ethical practices. And when I say ethical practice, that's one of the biggest USPs that we have today to attract patients from all over. You wouldn't have a single cardiologist of mine who would put a single stent, which is, even if he says there's an iota of necessity, that he can manage it medically. So that's the ethics that's inculcated in our doctors. They would never do anything just because of some commercial value, unless clinically, medically warranted. We are large. Out of the 31 hospitals, we have only 3 greenfield, all others being brownfield. I'm sure you know what's greenfield and brownfield. Yeah. So prior to coming to Bangalore, I was in central India, Chhattisgarh. In Raipur, I was running a hospital that was a typical acquired hospital. So it was an old hospital, about 20-year-old hospital, run by trustee members. And they didn't have a good reputation. Clinically they were bad, financially they were weak. Bottom lines were negative. So we said, hey, listen, we are good at this. We've been running this for years. Give it to us, we'll run it. So we made an O&M arrangement. And when I took over that hospital, 150 beds, in a matter of a year, we doubled that to 300 beds. So asset light always works better for us financially. We don't sink capital. We don't need to wait for a ROI, right? You start making cash flows positive right from day one. So this is a green field. The one in Calcutta is a green field. The one in Jaipur is a green field. All others are brown field. It could be O&M, it could be PPP. The one in Ahmedabad is a public-private partnership model. So we have largely these 3 models that shape up our 30-odd hospitals. So we have a cloud-based ERP system. So a patient comes to my hospital here, the same unique hospital identification number can be used to if he visits Calcutta. We strongly feel that feedback cannot be, in your terminology, it can't be autopsy, it has to be biopsy. Yeah, feedback has to be, service recovery has to be done then and there on real time. You don't need to wait for a patient to get discharged and then send us a feedback. By then you've lost the patient. So we have an online patient complaint resolution system. So they see something which is not right, they see something which needs to be corrected, they just record a complaint online. There's a number which is assigned to them, And then we have a resolution which takes place within the next 2 hours. It's called the PERL system. Supply chain, I broached this subject in the morning again. So we have over 70% of our procurement is done by the CBU, or the Central Buying Unit. That is, we procure for the group and not for a single hospital, which gives advantage to negotiate on pricing. Hub and spoke model for pan-India inventory management. Like in Bangalore, I have 5 hospitals and I've got 7 clinics across the city. So I would, if I have to procure something for the clinics, I wouldn't let the clinics do the procurement and negotiation. I would do that and then distribute from here. This is what Dr. Shetty was talking to you all this evening. We are very keen on, we are saying the future of healthcare would be digital and online. It would be devices, mobile phones. So with that in mind, about 4 years back, we launched a 24/7 radiology support. Like when I was running a hospital in Chhattisgarh, I never hired a full-time radiologist. We used to send the MRIs and X-rays and CTs to this center here, and it used to get reported from here. We always feel strong healthcare systems need to have strong clinical research arms and academia. They have to go hand in hand, without which aspiring to be a center of clinical excellence is not possible. We have a simulated surgical skill lab. I'm not sure if you have visited that place in this building today. No. Okay. So day in and day out, our surgeons, budding cardiac surgeons, the GI surgeons, they take time out and have simulated surgeries that happen, and they learn the fine art of grafting and suturing and incisions on virtual reality. Mysore is a place about 100 kilometers from here, and then we built the first low-cost hospital. We partnered with L&T and we told them, hey, listen, you have to build this hospital at half the cost and at half the time. And believe me, they delivered to their commitments. Prefabricated, there is no air conditioning here. Half the energy, because there's no artificial lighting, it's all natural ventilation and lighting. The hospital is doing phenomenally good. Our overheads are low. Our EBITDA margins are much better. So whenever you bundle pricing for a new hospital, you also factor in the amount of capital that you've sunk in, the overheads that's going to be there. Doctor payout is one small minuscule thing actually. Our doctor payout is about less than 15% of the gross revenues is the ratio. Yeah. So the other part is your consumables. So I factor in indirect costs is what we call. Your direct costs, your indirect costs, your electricity, your rent, the entire thing. So all that is in this Mysore hospital is much lesser than what we would encounter in other hospitals. And then Dr. Shetty always felt, if you have to start a hospital or in the States, you just need to park a ship over there. So it's something like that over here in the Cayman Islands, the Caribbean. We started a small hospital, with 100 beds. And we started off with cardiac specialty as one of the main things, but then things worked out differently there. And today we do far more orthopedic, your shoulder joint replacements, knee replacements, and GI surgeries than cardiac, doing phenomenally well. We partnered with Ascension Health, and who had a larger share. Just a couple of months ago, we borrowed the entire thing, and now we have 100% share stakeholder there. Yeah. I spoke to you about the micro health finance, your Yashashwini scheme. Of where their social background comes from. So with this social responsibility started Uday Pathe, where we fund soft loans for their education, and we've churned thousands of doctors through this program. We've got 2 buses here, which is dedicated for the screening of breast cancer. We call them Mammo buses. They go out far and wide to the rural areas, all the villages, and screen patients and detect them early, and then we can start the treatment earlier. So we said the need to have the screening. These are some of the publications that we mentioned. Any questions? Or we should have that during the panel discussion.
Yeah, that's good.
Thank you.
Thank you, Mr. Joseph. Now I'd like to call upon Ms. Divya Ramasamy. She is a Senior Faculty Associate of Lions Arvind Institute of Community Ophthalmology. Please welcome her with a huge round of applause.
Good evening, everyone. It's a hard act to follow, sir. Thank you for that very inspiring talk. So I'm honored to be part of this evening and to be sharing the Arvind story. I'm assuming you haven't heard of Arvind, so I'll be giving you a little bit of the background of why Arvind exists and give you an overview of the Arvind eye care system. I think the one thing that is very similar to the NH story is that when you try to do the right thing, it always works. And you also end up doing quite well as a result, and we've certainly experienced that at Arvind. So I'm glad to be sharing the story with you. I'll start, just as Mr. Joseph did, with the bigger picture, because this is really the reason why Arvind exists. The problem of blindness is really large, and India, for some reason, has the largest number of blind people. We're suspecting it's because of several environmental factors, but also because Indians genetically are predisposed to earlier cataracts, which is cataract being the leading cause of blindness. So if you look at this number, it's a large number, but the irony is that 80% of this is needless. It's treatable, most of it is treatable with a simple cataract surgery, simple compared to other surgeries. And even more simple by dispensing a pair of glasses. Now, so far I've been talking about people who we term blind. You know, there is a definition for blindness that is worse than 6 by 60 vision or 20 by 200 vision. But if you look at India as a whole, we think almost 1 in 5 Indians need some form of eye care. They need glasses, they may have diabetic retinopathy, they may have glaucoma, several reasons for why they would need eye care. India does have one of the most, I would say, progressive national programs that give subsidy for cataract surgeries when you're doing it free for rural and poor patients. There is a nationwide program that supports eye care, which is quite a lot for a developing country. But yet we see that less than 15% of this burden has actually been reached. You know, India does have a significant number of ophthalmologists, but yet we see that we're not being truly effective. And we're going to see why that is and what we can do about it and what Arvind has done. So Arvind, started by Dr. G. Venkataswamy, today exists with a fairly simple mission. We want to eliminate needless blindness, and we want to do it by providing compassionate care, high quality care, ensuring that it is reached by all. And when we say all, it's for those who can afford it, those who cannot afford it, those who are seeking it, even those who are not seeking it. So anybody who needs eye care must receive it. So that's basically a simple but ambitious vision. And even while he was there, he was very passionate about this. He pioneered the iCamp system, the outreach camp system. Even while he was part of the government, he got the government to support this scheme. But when he retired, he was still restless because this problem was still largely underserved, largely unaddressed. So he started his own private practice as a 11-bed clinic as a non-profit trust, but he continued to do. There is always that afternoon lean period in a private practice, and that's when he would do these half-day outreach camps and bring back patients, early morning doing surgeries. So being completely focused towards the problem of blindness and trust. And then 6 outpatient clinics where there's 1 or 2 ophthalmologists taking care of delivering outpatient care, not doing surgery though. And we now also have 65 rural primary eye care centers. We call them vision centers. They don't have an ophthalmologist. They have an equivalent of an optometrist who is trained and stationed there, and patients receive care through telemedicine. We're also a postgraduate institute for ophthalmology, so we're also training residents in ophthalmology, we're training fellows who want to do super specialty within ophthalmology. We're also training paramedics and technicians and administrators, all in the field of eye care. So last year we did roughly about just a bit over 4 million surgeries, about 60% of them being cataract, but also other specialties. About 600,000 spectacles were given. And 50% of this is provided either completely free to the patient or at a very steeply subsidized price. So you will see, this is the growth, I'm sorry the yellow is so pale, the growth of surgeries over the year. Today, the patients self-select whether they want to pay or get free services. So patients can walk into the facility, they can choose to go through one door where they would pay market or the lowest in the market prices, quite competitive prices for eye care, or they could choose to go in through the free door and get the same quality of care, but they would get it completely free. They would have to pay an equivalent of about $12 for a complete cataract surgery package. It includes everything, including stay. And if they came through the outreach camps, it would be completely free for the patient. So this is the split, and you will see today that what earlier used to be 30% paying, 30% paying, 70% free, slowly has now become 50%, almost 50% each, mainly because the Indian government has now started this scheme where it gives free insurance, medical insurance for people, for the poor, and they are now able to access care through that scheme. So they can now appear as paying patients, not for cataract, but for specialty surgeries. Now I'm going to just digress a bit because the story of Arvind is inextricably linked to Dr. V and his philosophy. So he passed away in 2006, but this video excerpt really captures the spirit.
I used to sit with the ordinary village man because I am from a village. And suddenly he turned around and then you seem to contact his inner being. You seem to be one with him. But he is a soul which has got all the simplicity of confidence. Doctor, whatever you say, accept it. An implicit faith in you. And then you responded. Here is an old lady who has got so much of faith in me. I must do my best for her. When we grow in spiritual consciousness, we identify ourselves with all that is in the world. So there is no exploitation. It is ourselves we are helping. It is ourselves we are healing.
So this kind of really captures the spirit in which Arvind operates. The decisions that are taken, no? So this really, I think, gives you an idea of what Arvind is or rather how Arvind functions. What it's working towards is clearly the large number of people who remain blind, but keeping in mind that you are completely patient-centered, that you're doing the right thing for the person who's not even asking for it. So, which means you really need to design your services, not only for somebody who's walking in through the door seeking your care, but for that old man who's sitting at home who's not seeking eye care. So one of the early innovations was the outreach camps, which where we would go out into the villages, a team would go out, screen patients, do a comprehensive eye exam, because usually that's the only chance the rural folks would have at eye care. So we're not only looking for cataract, we're doing a comprehensive eye exam because most eye diseases are asymptomatic. So we're doing, there is a clinical protocol for how we screen for most eye diseases, and we try to complete the loop as much as possible at these outreach camps. And those who need surgery are then brought back. So this and all of these camps that we do, clinical team would then do the clinical work. So they would do, and as you see, this is the standard protocol. There's somebody who's doing the basic visual acuity testing. The doctor will do a preliminary examination and then triage patients. They would go for further investigations as required. They would get a full refraction if necessary, and they would be given a prescription for glasses. Those over 40, we suspect glaucoma, so we would check. Earlier we used to use the Schwartz tonometer, now we use what's called a Perkins tonometer, and all the other tests. The doctor would finally then sign off on the prescription. If they need glasses, they can choose a frame of their choice, because that's very important, the aesthetics. We take an inventory of glasses. Patients would pay about 200, everything else is free, but they would have to pay for glasses, 200 to 300 rupees. So within about half an hour, they would get a custom-made pair of glasses with their power that they require. There's an 85% uptake on the glasses, even though they have to pay. Those who need surgery are counseled, and that same afternoon, they are bussed. So, and all the publicity includes all of this communication. So patients come to the camp expecting this, so they're ready, they have their small bag with them, with their clothes. They brought, the necessary investigations are done that evening. Then next morning, they would undergo surgery. We keep them for 2 more nights. They receive medicines, a lot of counseling, and then they're sent back home. A smaller team would go back to them after a month and then do a review camp. They would do a follow-up, for the 1 month post-op follow-up to make sure everything's all right, to dispense reading glasses if necessary. So this happens day in and day out, and several patients are benefited through this. We do, and we continue to do this because we reach over 500,000 patients. We are certainly giving vision to close to 90,000 patients through this. But then Dr. V is always asking this question, is this eliminating needless blindness? Is this enough to eliminate needless blindness? So what is the real impact of these screening camps? We do continue to do this because it's still helping a lot of people. But if I look at in one village where I'm doing the camp, we usually pulls from a drainage area of about 5 to 7 kilometers. That's the natural pull where patients would come. So if I went to them and asked them, how many of you needed eye care? So we did a study in '96 and asked patients who self-reported, now these are not people who we found having eye care problems, but who self-reported that they have an eye problem. Of them, only 6.8% of them actually came to a camp. Because if you really think about it, a camp happens at our convenience. It happens when Arvind wants to go. It may happen once in 3 months, it may happen once in 6 months, it may happen once a year. But if I'm not ready to seek care on that day, if I'm busy that day, then I have to wait. If it's an acute problem, then that camp is not on demand for me. So this was, while it was doing a lot of good work, camps were not going to be the solution for creating the impact we wanted. So one of the things that we wanted was a more permanent presence, a more permanent way of providing on-demand care for patients when they wanted it, where they wanted it. And that really has gave birth to the primary eye care model or the vision center model. Is this so this is a typical vision center, they're usually in a rented building. Every patient pays 20 rupees for registration, which is roughly what they would, maybe half of what they would pay to come to the base hospital by bus. So they get, again, a full refraction. She is trained to do a complete preliminary eye examination. She does the full refraction, she would take blood pressure, if they're over 40. If they haven't had a blood exam, she would also use the glucometer to check if they're diabetic. This is a slit lamp where she does a full anterior examination and also looks at the posterior part of the eye. She's also examining the retina. And she enters all of this into an electronic medical record. At the same, then she's presenting it to the doctor who is at the base hospital. So there's always 4 doctors who are on a monthly posting, it's a rotational posting. So this is the doctor, she can access any of these centers in queue. She would look through the medical record, interact with the sister as well as with the patient. The patient has a chance to explain her condition and her problem. And the doctor also counsels the patient directly. And then the doctor would also key in into the same medical record. The doctor would key in her advice, her prescription. So she is prescribing glasses for this, and then the prescription is printed out at the center with the doctor's digital signature. And if they needed glasses or drugs, they would be able to buy it at the center itself. And so this kind of closes the loop. So this is one model that we're really excited about. We have 65 of them and we're hoping to take it to about 140, mainly to cover our service area. But we're also really advocating this model because what really excites us is now, for the first time, I think because we're now talking at a very granular level, we can actually talk about coverage, which you cannot talk about when you're talking about tertiary care and secondary care. And we're seeing that the coverage of those who need eye care is something like even 40% in the first year, rising to 75%, 80%. We can really talk about localized chronic care for chronic eye conditions. So all of this becomes a possibility suddenly when you have a center in a local situation. And the other exciting thing is 91% of the problems that the patient comes with is resolved locally. Less than 10% of them need to be brought to the base hospital or need to be asked to go to the base hospital for further investigations or surgery. The other thing that excites us is whatever income the center is able to make through glasses, through consultation, through medicine sale, is more than covers their operational costs, that is the rent and the salaries of those staff. So this becomes a very sustainable model. So while we're doing all of this to generate demand, to bring patients into the model, it puts a lot of pressure on an organization that is already suffering from scarcity of resources. And this is true of any organization, any developing country. So this is a typical cataract theater where you will see as a doctor is performing surgery, there is a very efficient paramedic helping him, expecting his every move. And at the same time, the patient near him has been prepped. So he just has to move the microscope over. This distance between the tables, all of those are calibrated. So he just applies antiseptic rub and then he starts on the next case. So the doctor can do surgery as fast as he can or as slow as he wants to, but because he's the most important resource, the most expensive resource, he is never kept waiting because the system isn't ready to give him patients. And we need to do this because there are a lot of patients waiting to be served. So unless we bring in this efficiency, unless we're able to lower costs, we will then be burdening the healthcare delivery system. The other thing that makes this possible, besides the systems, is the task shifting. A lot has been done to take away unnecessary tasks from the doctor, but at the same time train a very good supported cadre to take those tasks on without compromising quality. We've been taking girls from the rural areas, girls who've just finished school, so they've finished kindergarten plus 2 years of school, plus 12 years of school typically. and then they undergo a 2-year structured training program. Today we've moved on to a competency-based training model where we really hold ourselves accountable for delivering the skill and making sure that they're really competent to perform that skill. And everything at Aravind, we try to make it open source, so all of this training material is now available on our website for any eye care organization to use. So in this way, we've been able to ensure that doctors focus on diagnosis and surgery. This has also helped improve the quality, lower costs, and in the bargain, the girls also themselves may not be faster or better, but it's a system that is able to give him more patients. The system allows him to maximize his productivity, makes an Aravind surgeon far more productive than an average Indian surgeon. At the same time, not compromising on quality, both clinical quality as well as service quality. And this is only possible because of a very evidence-based decision-making culture that Aravind has built. Dr. V used to make sure that there was always a continuous improvement process throughout for any aspect, whether it was the camp, whether it was surgery, whether it was patient care, there was always data for measuring, there was always chances to review and learn, like you were saying, that there's always that biopsy is happening live as the work is happening. And then we see that even though we're providing close to 50% completely free or subsidized, earlier that used to be even 40% only paying, you can see that we've been making a healthy surplus. And all of this income comes from patient income only. Less than 6% of Arvind's income comes through any grants and donations. So this is the income and expenses. So we have a very enviable EBITDA, even though all of this is coming from patient revenues. Once again, going back to the question of are we eliminating needless blindness, we see that in the early 90s, this is just a bit of history, in the early 90s, intraocular lenses that needed to be implanted into a patient who had cataract used to cost $100 to $200. Even our paying patients, not all of them could afford an intraocular lens. So that's the intraocular lens on somebody's finger there at the bottom. But if somebody, so the norm was to do cataract surgery without this intraocular lens implant, which means you take out your natural lens, so you lose a little bit of, use quite a bit of your refractive power, which means you'll have to compensate by wearing really thick glasses after cataract surgery. So we in India were when we were as the late 40s, certainly in the late 50s, while they're quite a bit productive, and they would be sometimes the main breadwinner for the family. So imagine an old farmer who's got cataract and he's completely lost his livelihood because of this, having to negotiate a farm with these glasses. He'll have to negotiate bad roads, have to work very productive life. So at Aravind we really felt that this intraocular lens was key to giving good vision back. But because this was a luxury item, and I'm saying this because this would be appropriate to you, at that point we were not able to convince the manufacturers to bring down the price, even though there was a large demand. At that time it was as ridiculous as saying, let's do LASIK for everybody who's wearing glasses. It was considered a luxury item, and even the government of India was saying, you're going to ruin the market by bringing this and trying to give it to everybody. He's like, you're going to actually spoil the market. But what happened was, because it's basically a piece of plastic smaller than a shirt button, it started off as a one-room laboratory at Aravind, where Aravind said, let's try to do this ourselves. And overnight, the price of an intraocular lens dropped from $100 to $2. Now, everybody can afford it. Today, every cataract surgery has to be done with intraocular lenses. In fact, the Indian government mandated it almost immediately that intraocular lenses have to be implanted unless it's contraindicated. So today, Oral Lab has grown into, certainly IOLs is the mainstay, but also diversified into other products, trying to bring down the cost of eye care. Oral Lab at this price is no longer the most competitive price. So it's still a very competitive market even at this price point. So you can see how inflated it was at $100. It's being exported to over 140 countries. The quality means that, that they have 8% of the global market share, speaks of its quality. So we were able to do all of this mainly because we were focused on the patient and the community, but we were also making sure it was affordable to Aravind to be able to do this in a sustainable manner, but also be able to do it when most of your patients can't pay. So it really requires you to put it puts a lot of pressure on the organization to be as efficient as it can. So what Aravind did was, one, Dr. V in the beginning, all of this that I'm telling you is in hindsight. But when Dr. V started, he was saying, I'm going to do the right thing, money will come later. That was his philosophy. So he gave it away free. For those who were able to pay, we charged market prices, but also we were conscious that for everyone we had to give high quality care, because that's how you can keep your paying patients, and just having the mindset to do the right thing. So this is just a quick comparison for those who haven't seen it. This is Arvind's volume. So Aravind does over half of the state's eye care work in Tamil Nadu, which is comparable to the country, the whole of UK, the NHS. So we would do about 60% of the eye surgeries done by UK, and also because we're also just comparing that, even though both are doing training, Aravind also is comparable because they're also doing about 70% of the surgeons that the NHS is graduating every year. But then if you compare the costs, it's less than 1% of what it costs the UK. So this is, how do we unearth those inefficiencies in healthcare? Because all of that is borne finally by the community, by the patient, by the taxpayers. So it is critical. I think in being in India, maybe we were forced to do this because we're in such a resource constraint. But I think this is something that we'll have to constantly re-examine ourselves. Recently, we also published another paper completely out of healthcare in specific, but really looking at the other side of this inefficiency, but where this wastage is going. So it was more looking at cataract surgery and its environmental impact. So on your left, you will see the waste generated by one phaco surgery, one phaco cataract surgery in the US, and this is generated by 93 cataract surgeries with very similar or even better outcomes. So this is and then you will see that the carbon footprint by an Aravind surgery is about 5% of what happens. And when I say Aravind, this is today more commonplace throughout India. Hospitals in India would probably do the same things. It's not unique to Aravind alone. But I'm just pointing out, in the Western country, because of a lot of disposable material being used, there's almost no reuse. And in fact, the carbon footprint, because of the Aravind surgery, mainly came from electricity usage for the sterilization, that was where they were sterilizing the equipment for reuse. So in many ways, we need to become more responsible in the way we use our resources. So the last bit is about I'm saying what Aravind does, but whether Aravind can do all of this alone. We realized we can't, so that's why we started the Institute for Community Ophthalmology, which is really where we help other eye care organizations, where we help other eye hospitals, other governments, other NGOs working in the eye care field, to basically just sharing what Aravind does, sharing what best practices we have, helping them put in place the right systems, so that they can also do well, because that's the only way we can, because when Dr. V said eliminating needless blindness, he was not talking only about Tamil Nadu or India, he's talking about the global problem. So we've been working with over 340 hospitals, most of them in India, but over 30% of them in other developing countries. And we estimate that roughly this work has impacted about 750,000 additional surgeries being done each year across these hospitals, with improved quality, certainly improved, as you'll see here. The surgery volumes themselves double within a couple of years, but also these hospitals, typically NGO hospitals, are now becoming more self-sufficient because their quality of surgery is good, their paying patients are coming in, they're able to not depend on funding for doing surgery. This is my last slide. This is we're also, one other part of Arvind also focuses on different areas of research. People like myself, by the way, I'm not a doctor, I was introduced as a doctor, but I'm not a clinician. We would do epidemiological research, we would do operations research, because that's really where Arvind's contribution has been in the area of public health. But today we're also doing a lot of clinical research, a lot of basic science research. Today I was very happy to see the work going on at the eye hospital that is part of Narayana Health, also doing a lot of cutting-edge work in molecular biology research. So I'll leave you with this quote by Dr. V, and thank you for the opportunity.
Thank you, Ms. Divya. That's indeed a very inspirational story. And Dr. Venkateswamy's work reminds me of the famous quote by the father of our nation, Mahatma Gandhi ji. I quote, "The best way to find yourself is to lose yourself in the service of others." And this reminds me of a quote by Dr. Devi Shetty, who says, "None shall be turned away if they can't pay." With this, we're going to move on to the panel discussion. We're running short of time. We're going to have a brief panel discussion, and I'd like to call upon Professor Dr. Rainer Sippel from Germany. Huge round of applause for Professor Rainer Sippel. I'd like to call upon Mr. Aga Sultan, who's the chairman of Laureate Education and Welfare Foundation, Mr. Joseph Basanga, COO of NH, Ms. Neema Kachar, editor of India Med Today, Dr. Ali, founder of Eye Care for Billion, and also I'd like to request Dr. N. Girish from Neman's Hospital to kindly come over to moderate the session. Thank you.
A very good evening. Quite happy and boundaries, literally transcending the geographic boundaries and also transcending those unnamed boundaries what we are talking about. Well, I've listed out a couple of points during the presentations. What we'll do is, I think we have got about 15-20 minutes. We could focus on just one core issue in terms of how would each one of us look at defining accessibility and affordability. I think that should be a good focus for us over the next 15-20 minutes. But before that, what stuck out is, thank you Divya for mentioning that last quote, joy of doing something beautiful. I think let's do something beautiful before we break for dinner. Issue which comes out is, one, doing the right things the right way always works. Second, autopsy or biopsy. That stands out. Healthcare of the future is digital. That is the third one. When we are talking about access, are we talking about just primary care access, or are we also talking about specialized access? Or are we talking about a larger preventive sort of activities? The fifth point, which probably comes up within this point of access, is again the issue which Divya brought out in terms of saying, we just don't do for eye surgeries because it gets linked up to a larger health-related issue. So can we restrict only to a narrow one, or are we looking at a broad one? So keeping these 5 things in mind and also keeping the larger question in terms of how would we define accessibility or affordability? I'll request a team leader from Germany to take start in terms of reacting to the 2 presentations in terms of what would be the scenario in a developed country like Germany or in and around when Arvind hospitals have shown that it is less than 1%, 1 to 5% if you look at across the board, number 1. Second, I was also looking at the Narayana model, which has scaled right from, which has transgressed the teleradiology and telemedicine part of it, and also to the Mysore experience of a very low-cost, effective model.
Okay, thank you very much for that question. Well, from my perspective, as I have no medical background, I'm a simple economist. Both examples are tremendously convincing in sense of that is the way we, from a business administration point of view, would argue in sense of there are efficiency gaps in the way how we organize healthcare so far in a lot of countries. And both examples from a business administration point of view are perfect examples for so-called focused factories. In the sense of there are areas in medicine, and especially when it is surgery-based, where you really can play this vertical cycle of realizing economies of scale. You know, because there is clear evidence that the higher the volume is, there are learning curve effects, there are economies of scale doing the procedure, and it's back up. That's one the example from Narayana. You can back up that if you have volume, there are additional economic synergies in sense of procurement, you can negotiate better prices, stuff like that. In that sense, these are perfect examples to show that volume is related to quality. It's not in contrast to quality, it's really driving quality, and at the same time it saves costs simply by economies of scale. The tricky question about that is how can we transfer that on an extended view on healthcare, in the sense of we also have internal medicine where we also know and have evidence that the degree of economies of scale in these areas are much more limited. There is much less material and stuff like that where you can play this procurement game. The procedures are not related to or have much less learning curve effects. There is clear evidence to that. So how could we transfer these kind of concepts to a more holistic approach of medicine, treating patients, providing health? And another concern or challenge we are facing with is it is a wonderful story in sense of treating tremendous serious basic needs for poor people. You know, blindness is really a substantial disadvantage. Heart problems, these are really very essential basic needs. Nevertheless, if you look to the disease burden we are facing, and even India is going that way like all the other countries, the wealthier a nation becomes, the burden of disease is changing. And it's changing in the way of chronic diseases. And chronic diseases are multifactorial. They need interdisciplinary approaches of medicine working together. And according to my knowledge in research, we still have a challenge to answer that question in sense of what is the model to solve that. In sense of focus factor is tremendously fine, but it works for a dedicated focused area of procedures of medicine, of kind of medicine. There are discussions in sense of hub and spoke model, which is already implemented here, and my understanding from Narayana, LCT is to implement that idea, and we are looking very much forward to this experience to extend the spectrum of medicine that try to treat. Yeah, and one thing is clear, access, the biggest, from the patient side, access borders means affordability. And the lower the prices, the lower the cost, the lower the prices, the lower the access border is. So it is really only to support and to appreciate these kind of initiatives. Yeah.
Thank you. I think you put the right perspective there. But question is, what can you name a barrier which prevents this transformations to happen, or the paradigm or the lessons to be implemented?
As I said, the one thing is the need of the patient.
Okay.
And the need is partly tremendously focused in sense of this is an individual specific need like this. But immediately when the need becomes more complex and different kinds of medicine have to work together, have to bring at the same time, at the same point to the patient, then this model has limits. Nevertheless, we can try to, in the discussion with Dr. Shetty, we still can try to overcome burdens in sense of, how to bring at the point of time to bring all these disciplinaries together. Does it mean all the physicians have to be there? No. We have technology to enable this interdisciplinary exchange in sense of communication, in sense of information flow. There are a lot of new technologies to support that.
Okay. Thank you. Thank you. Yes, sir. You're good.
My name is Aga Sultan.
Okay.
I have been associated with the educational system of Karnataka and India. I have been in the university system, Prime University, as a syndicate member, as well as the founder member of the Vishwavira Technological Institute, as well as All India Council for Technical Education. Dr. Shetty is a very close friend of mine. I have known him for almost 2 decades. This NH hospital started in 2001. Believe me, what is important in medical field is medical ethics, which normally we don't talk about. Now, what is medical ethics? Today, there is a big storm in India regarding corporate culture in hospital business. But let me be proud, though I am not a part of the NH management, I am a friend of the NH city and a friend of Dr. Shetty. I have not seen anybody on this earth. There is only one Dr. Shetty. I am not trying to utilize him or praise him. I am going to tell my story in 2-3 minutes of his service to the downtrodden and the affordable health care that he has delivered, and to the poor and needy that he has helped. Way back in 2001, this started, and it started as a heart institute, Narayana Hridayalaya. A lot of people, see, we have been in social service, Mr. Vanger Sibu, in helping poor patients get operated. So I met him and I told him that there are a lot of poor persons who cannot afford it. He said, send them to me. Let them pay what they want. And if they don't, I will do free. The journey started from there. And we set up a telemedicine center in Iraq after the fall of Saddam. In that war-torn country, we set up a telemedicine center in Iraq, and Dr. Shetty sent a number of doctors there to see the patients. And he used to operate from here, treating patients there via the telemedicine center. Also, a number of children, a group is there, Moiz Hussain who sponsored it, and our association. We have done a number of heart surgeries for poor children. And the basic principle is take from the rich and give to the poor. The rich pays it, and poor also benefits from it. So this is a social justice. And believe me, when a patient comes into a hospital nowadays, the first thing is the target of the doctors. It's the targets. The target.
I'm also worried about the time, that is what I was just...
Yeah, I'm just telling you, targets. Normally the hospitals put the targets on that, but this is only one hospital who doesn't put the target. Medical ethics is followed 100%, and I'm proud to be a friend of his, and I'm proud to be here with you.
Thank you. Thank you for defining that access is reaching out to the poor and the needy, who really cannot afford to get treatment. That's where it gets into. Can we have the journalist perspective in terms of, can we have your thought? What would be a good case study?
I would like to digress from what we're discussing a bit in terms of saying that when we talk about access, we are always looking for the answer outward. We are always looking for something that will allow us to bring access to people. But in India, there is a problem where we can look inward. Our medical system and the way healthcare functions in India, the regulations that are there on doctors and other healthcare workers. If Dr. Shetty was here, he would like to say that access to essential surgery is one of the largest killers globally. 16.9 million people die due to lack of access of surgery, and it is not just the access of a hospital or a doctor, but even if a doctor is present, like an MBBS, pure MBBS who studies for 4 years in India, is not allowed to do simple bellwether procedures, which are simple laparotomy or emergency C-section or a fracture surgery. These are simple things which can save lives, and these are not available to people because of the regulation of the country. Because the regulation doesn't allow a doctor to perform these surgeries.
Thank you for bringing that essential point where the regulation itself becomes a barrier to look at accessing care.
Yeah.
Thank you. I think we'll just now take a couple of quick questions from the audience. Please shoot your questions to any one of them.
I think my voice will be louder.
Okay.
Okay. I'm Mamdouh Al-Ahmadi. I'm the Deputy Director of the Heart Center in King Faisal Specialist Hospital. My question will be to Mr. Joseph. You clearly have the advantage of 700 operations, I think you said 700 operations a week. If I made my calculation right, maybe 600 out of those will be ending adult operations every week. Now, for cardiac surgery, still remains the supply or what we use during the surgical procedures are the most expensive, and we speak about the bypass itself supplies and then whatever implants being placed in the patients. You may have said it, but I'm not sure how many adult surgeons you have. And the surgeons, they have a tough time to deal, or us, especially cardiac surgeons, we are tough to deal with in what are our selections for valves, for bypass materials, what to use. How did you get, I don't know whether you use the same type of valves, the same supplies for the bypass machine here or other hospitals, and if you're using the same, how did you get all those surgeons to agree on the same supply? Because it's one of the issues I meet every day when I talk to my surgeons.
How think you standardize?
Extremely valid point. I think when I joined this hospital, and Dr. Shetty told me, if you can run this hospital, you can run any other hospital in the world, and especially a cardiac hospital, because initially I came to run the cardiac hospital and dealing with the cardiac surgeons. He says doctors per se have huge egos, but when it comes to cardiac surgeon, it's the ego that comes first, and then comes the doctor behind. So you rightly said we got about 19 adult cardiac surgeons and about 9 pediatric cardiac surgeons. And each one would have their own earmarked operating theatre, their own perfusionist, their OT technician, their nurse, and Kia Xylem. Yeah, that was what used to be. That's where Dr. Shetty started it, and it was more of a Dr. Ram thing, and then came administrators like us. And then I said, well, Dr. Shetty, see this surgeon here, he owns only one particular van. Like typically what do you say? And he says, no, I use the other van, I lose my patients. He says, you leave that to me. So what he would do is, he would first try out that valve, which is inferior not in quality, but in price. And then we have this mortality meetings every week on a Friday. And they present cases. And then he would very uncannily, bring up this case. It's a very complex case, but then we thought we'd lose it. And then he would say the consumables used. And then he'll have this, valve which is supposed to be thing. He says, I use the same valve. And then he wouldn't let them to deduce or infer. And then it's kind of understood that you can still use another valve, which is priced lower to another thing, and then that becomes the standardized thing. So we say if those three doctors can use this particular stent or this particular valve, then why can't the others? And we show data. It's very important for us to show the data to the surgeons and then make them build. We're not forcing them, but the data speaks for itself. And as I said, our doctor payouts, we also factor in the costs that each surgeon would incur for a surgery. So during this mortality meetings, we also would put a slide there where you will have surgeon, including Dr. Devi Shetty and the 19-odd surgeons, what was the length of stay of each surgeon, what was the cost involved for a particular surgery, the average cost. Would just be put it's like a report card. And we would say, that's all self-explanatory. So that's one way of, how we start standardizing. Stents, for example. They used to have stents from 10 odd companies. Then we said you have a choice. You can use 2 companies. And then there was consensus, they fought, and then finally they said, okay, 4. 4 became 3, and 3 became 2. So today we have just 2 standardized stents. So that is a huge challenge. But then once you show evidence data, I think it's easy for us to buy them in. And one very valid point for future administrators of hospitals, I should say, is running a hospital is not like running any other industry. It cannot be us and them. It has to be inclusive. You take them along during the decision-making process. You make them party to the consumables and the pharmaceuticals that you're going to stock up. And believe me, the consensus and buy-in of the surgeon is easy.
Yeah. Thank you, Joseph, for letting the cat out of the bag, for sharing. Yeah, we have please identify yourself and then.
Myself, Amit, from Bangalore Medical College. As a student, I want to ask why these people are not aware, making medical students aware of these many facilities. Like, if somebody comes to the doctor somewhere in the village, he is in the PHC, and some patient is a cardiac patient comes to you, you will refer to his friend in the city. Not because he is not educated about these facilities available. He doesn't know what are the steps.
Okay.
Yeah.
Is it for any particular person or is it to any one of them?
Anyone who can.
Okay. Who would like to answer? Dr. Ali, would you like to take that? Sure. Because I thought your theme of one care for the billion stands
that's a very good point that actually I want to put it across saying, access to healthcare first comes by educating people. I think that is very important. Now you go to any village in India, any remote space, you will still find a primary health center which is there. The only point there is the doctors are not sitting because the whole trend is the doctors who wants to know after finishing so many years of medical school, and then we want to be in a 3-tier city to have our own comfort zones. So we have shortage of doctors when it comes to doctor-patient ratio. So for that, I believe first is required is educating people. Having said,
because if you can't educate all the because if you educate a doctor, you will educate all the patients who are coming to you. So why can't you educate the doctor or the medical student directly?
Okay. I get your question. I get your question in terms of saying, what is that mechanism wherein doctors are able to know what is the treatment cost at Narayana Hrudayalaya so that I could say.
What are the steps?
Where is the Madurai Eye Hospital equivalent available nearer to Bangalore?
Even the medical students,
yeah,
they are
I think
available
that's
at one place.
That's a larger question which we need to address in terms of, yes, Neelam, would you like to?
So, one of the ways in which you can get information is read, I would say. Read my magazine. But on a serious note, as you finish your MD in whatever subject that you have taken, you will know in India which centers are doing good work and what is available where. As you finish your MBBS and as you...
But all doctors doesn't do MBBS. Some will be working PhDs.
Yeah, so the way to know is if you are into that particular subject, say ophthalm, and people will know, like there are certain names that everybody knows in India, I guess, like Arvind,
I think I'll just put a hold on this. We could continue with. I understand your point of view.
No,
there's a larger.
I want these people to take one step ahead and educate at least medical students.
Yes.
They are at one place.
Point noted. Point noted. Please give him a big hand for the reason he's raised a very important issue in terms of medical education. How things can be streamlined.
At least Narayana can come to our college and educate.
Thank you.
You're very right. Thank you so much. And that is why we have joined here. And that is the idea and the cult behind I Care for Billion is where you've been educated. So what I request all the medical students to please go www.icareforbillion.com. And that's the place you find educating people. And that's the whole point of introducing and inviting international delegates here to, introduction of World Healthcare System and learn about it. And not just learn, also know your real time where you find your hospitals nearby with kind of specialty of what hospital will provide. So, thank you.
Thank you. I think that's a larger process in the health sciences education which should happen. I think they had one more. One in the last room. Someone had raised their hands earlier. No? Okay, yes sir.
Yeah. I'm Dr. Raza. This is just to clarify, Madam, that she said one of the reason is regulation. That is the barrier for the accessibility. But I differ from what she has said. She said MBBS students, once they come out, they should be allowed to do surgery. Why I am saying this? Because being a surgeon, see, MBBS is just a studying process. They are not practicing. They are just studying and they are just watching. Just by studying and watching, nobody can do any surgery. See, we have a post-graduation course, Master in Surgery. They undergo 3 years of rigorous training. They assist, and then even after that, they will not be able to perform surgeries. After MS, again they will have to work 2 years to gain the confidence of doing surgeries.
Sir, noted. So, just because of time, I am cutting short.
It's not the barrier for the.
Just to put the things in perspective, I'm sure, being a non-medical person, at some point I would give a margin in terms of, for doing a simple episiotomy for primary delivery could be a point. But we need to start defining those surgeries. Now, being from a National Institute of Mental Health Neurosciences, I know for the next 30-40 years, you are not getting the adequate number of psychiatrists in the country. And that's not just the case with India. If you look at it world over, that's the trend. So, task shifting and the new task roles which needs to be defined is a priority matter when we are seeing at expanding services and increasing accessibility. Okay, I think with that we can have more discussion on this, but we need to clarify that it's not laparotomy which may be required, but a simple episiotomy is something
they are doing it. I think that they are doing it.
There are some legal issues which come up, or suddenly there is a scare. I think we can look at it.
I was only trying to bring up the regulation part where you need to do what you said correctly, sir. You need to do an MD/MS, and there is also a College of Surgeons and Physicians in Maharashtra which does a diploma course. So there was a regulatory battle that that course was not recognized because it was a shorter duration, and that other course was recognized. So
Yeah, I think
these are
we are opening up a
regulatory
larger debate in terms
Yeah,
of what's happening
these
with
are the
respect to
regulatory
the
matters
Commission.
which are pertaining
So,
to India, not.
We'll not get into that area for the evening. Anyone else would like to have the last question for the day before we ask the panelists to make their final comments? Anyone from the audience? Accessibility, affordability, vis-a-vis the quality and equality. I would like to address it to Mr. Joseph.
Come again, sir.
How do we balance accessibility, affordability on one side versus quality and equality on the other side?
About 7 years back when we went for the JCI accreditation, the Joint Commission International Accreditation, the stamp of quality from the US, and people infamously asked, Shetty, you're a low-cost hospital, so why do you want to go for JCI? And he retorted saying that precisely is the point why we need to do this, because when we say we are a low-cost hospital, the perception among people is that we cut corners on quality. So we went through the JCI and we came out with some of the least ever in-season observations from JCI, and today we are on the third JCI re-accreditation. So when you when you cut down costs, you need not necessarily compromise on quality is what I'm trying to say. In fact, it's the other way around. You're so much more conscious about the quality of outcomes, because you know these are all low-cost packages. A small negligence in clinicians or a nurse's part can end up getting the patient to stay back in the ICU and antibiotic usage, and the burden of cost comes to the hospital. So both are intertwined, is what I'm saying. Yeah.
Thank you. Thank you. I think, Madam, would you like to add anything to it? I think Arvind Eye Hospital experience in that sense stands out. I still remember an anecdote about former late President APJ Abdul Kalam standing in the queue when we have read that in WhatsApp messages across.
Yes, I think both to answer your question and the previous debate, I think whenever we talk about addressing the healthcare issue, there is a demand side and there's a supply side. We can't just look at what we are bringing to the table as providers and then say the market has to figure it out. Because the market can't, there's such a knowledge gap in healthcare. So we really need to draw the boundary differently. It doesn't stop at hospitals' doorsteps. Like he's saying, no, you should take responsibility for awareness. You should take responsibility for access. Which is, I think, what we should do. So we should keep on shifting that boundary of what we are responsible for, and that's how we'll make change. But also, this question of quality, accessibility, and regulations. So just again, in the same paradigm of demand and supply, today doctors cannot do surgery because that's how the design is. They're not trained to do surgery. But the need is there. So what are we going to do about it? Should we say doctors can't do surgery? I'm not going to answer that question. But in Africa, in Ethiopia, there are so few ophthalmologists. Everybody's going blind because of cataract, because everybody, if they live long enough, is going to get cataract, and there's nobody to do the surgeries. Today, non-doctors, I'm not saying non-ophthalmologists, non-doctor cataract surgeons do cataract surgery with equal quality. And they have really helped in reduce the cataract burden, the blindness burden of the country. Unfortunately, that's been stopped because of regulation. So it's really how do we take responsible decisions? Because we really want to address the demand, we address the need rather. And then how do we be brave enough to make change, to make some radical changes to how we design care? Because if we continuously stay focused to the need in the community, we'll come up with some innovative solutions.
Thank you. Thank you. That requires a paradigm shift, a change in mindscape, in the landscape. So last question to you in terms of Professor Rainer, to say, how would you balance this demand and supply issues related to Europe or the other countries? How would you look at it, especially in terms of cost, qualities,
I'm very happy that demand and supply, these kind of terminologies usually more on my side.
We are taking over the economics.
But there is one clear answer in sense of, as an economist, you look, where's the shortage? And obviously, in a lot of areas of healthcare, the shortage is on the supply side in terms of HR. We simply are lacking qualified people. The question we can address is what we qualified. For what kind of services do we need what kind of qualification? And the leverage we are talking about, especially in an environment like here, and based on the examples we have seen there is, the key leverage from an economics point of view is the leverage of standardization. The more you standardize, the more you can address clearly the question, if that is the standard, and we go into volume because of economies of scale, we can also ask the question, and if somebody has to follow that standard, what are the qualifications this person needs? And then you can come across in the sense of, do I need a general surgeon which has a huge flexibility, or is there a potential to teach somebody a smaller range of surgeries, but on a shorter level, and to simply increase the capacity you have in sense of HR to overcome this supply. The leverage is always all around standardization, and this is something which, as an economist, is somehow in contrast, please apologize, but in my impression, in contrast to the self-understanding of medicine. A lot of physicians don't like standardization because they have the impression standardization is limiting my competence, it's cookbook medicine. So the perception of standardization, which is a very positive one from an economic point of view, is maybe not the same in the medical profession. And that is, I think, we should work on even during education maybe, that they understand that standardization is a positive thing in the sense of it increases quality, it saves cost, and gives me a brilliant job.
I think those of us who have been in the system for a long time understand how things have changed. Things have changed 10 years, 15 years to now. A lot of things have got standardized, but I think what you rightly said, it's a progress and a process in which we are involved in. Okay, I think we come to the end because my watch shows 8:55. Hunger and anger always go together. We need to look at accessibility for the dinner now. Let me also... Now, when I was sitting through, waiting for all of you, I was reading through, my colleagues had forwarded the Supreme Court judgment on passive euthanasia in India. It was delivered 2 days back. That raises still more larger issues when we talk about access. I think with that, please give a big ovation to the entire panel. Underscoring thing is, one, we need to look at the systems approach, and it's not just the individual, but the whole purpose in which we do these things. I think that is where we stand out, and that is where we need to look at reaching out to those 1.3 billion Indians, not just 1.3 billion Indians, but possibly I'm sure it must be 8 billion plus the global population. I'm sure that is what we are here for. Let's learn from each other. That's what is the lesson which our young medical student has brought it out today. Let's give a big hand for all ourselves for making it possible today. Thank you. Thank you for all the panelists, and now hand over to the organizers.
Before I call upon Ms. Neelan to propose a word of thanks, we have a few mementos to be handed over. I request Mr. Joseph to please hand this over to Professor Rainer Sibyl from Germany. Now I request Mr. Aga Sultan to please hand over this memento of Dr. Devi Prasad Shetty, and I request Mr. Joseph to please receive it on his behalf. I'd like to request Mr. Joseph to please hand this over to Dr. N. Girish. I request Mr. Aga Sultan to please hand over this to Ms. Divya Ramaswamy. I call upon Mr. Dr. Mohammad Raza to please come over and give this to Ms. Neelam Kachar. I request Professor Raina Sibil to please hand over this to Mr. Aga Sultan. I request Mr. Joseph to please hand over this to Dr. Ali. Now over to Ms. Neelam Kachap, who's going to propose a vote of thanks.
Good evening, ladies and gentlemen. It's my privilege to have been asked to propose a vote of thanks on this occasion today. And on behalf of I Care for Billion and the entire team, I would like to thank Chairman Narayana Health City, Dr. Devi Shetty, for his kindness and willingness to host us today. He's not here. Thank you, sir, for taking time to have us and interact with us. I must mention our deep sense of appreciation for Mr. Aga Khan. This event would not have been possible without your support, sir. Thank you. Further, we are grateful to Professor Sibil and all the delegates, all of you who have come, traveled so far and come to India to learn about our healthcare models. I hope this event has added valuable insights to your ongoing quest for knowledge, and someday you will use it in your own countries, and probably India will also benefit from your learnings. We are very grateful for Ms. Divya Ramaswamy from Arvind Eye Care and Dr. Girish for spending time here today with us. And finally, I would like to acknowledge the hard work put in by Dr. Ali and the I Care for Billion team, Dr. Zakaria Abbas, thank you, and the volunteers, the staff of NH, and the audience, and the delegates, thank you all. And thank you, Joseph sir, for being us.
Guys, thank you for everything what's happened today. Thank you one and all for making this event a pure success. But I also apologize for the short of time and delay. I think that's part of life. Also, I'd like to thank Narayana Health for hosting us and making this event a fantastic. Thank you, Mr. Joseph, for giving us an opportunity as well. And thank you one and all. And now we can proceed for the dinner. Thank you.
Well, this would not have been possible but for Mr. Joseph. Let us give a standing ovation. And his team. He is the pillar behind this. Thank you very much. And his team of officials, Mr. Lakshman, all are there here. Everybody did a wonderful job. The videographer, the photographer, Mr. Roshan and Mr. Bhavan. Thank you.
Yes.
I'll send you a test mail. Thank you.
Don't move.
Thank you.
Wait.
The delegates actually.
You all think that there are